just want to introduce myself because I am a vascular surgeon and I've not been involved in ERAS, but since 40 years I've been interested in venous thromboembolism and how to prevent it in relation to surgery. So I will deal with those problems, some general comments on surgery and venous thromboembolism, some general aspects on prophylaxis, and then turn into ERAS and venous thromboembolism, where there is not very much performed yet, and then some conclusions. Venous thromboembolism is, I think, one disease with various manifestations. It can be asymptomatic, it can give symptoms, and whether it's asymptomatic or symptomatic, it can give rise to pulmonary embolism. And pulmonary embolism, of course, can be fatal. One problem today is that the autopsy rate is very low, so we don't really always know what the patients die from. In Sweden, we are down to some 10% autopsy rate. When I started these studies some 40 years ago, we had 85 to 90% autopsy rate, so we could really tell what the patients died from. Sometimes you hear that asymptomatic thrombosis is a surrogate for thrombosis or thromboembolism, but I don't agree with that conclusion, because there are many things pointing to that asymptomatic thrombi also are dangerous. There is a correlation between asymptomatic deep vein thrombosis and venous thromboembolism. Asymptomatic thrombi can embolize and they can also be fatal. Untreated asymptomatic thrombi can progress to symptomatic and also very large ones. And prophylaxis reduce asymptomatic thrombi in parallel with pulmonary embolism. And it's the same pathologic process, and it's not the clot. You can now and then see in written papers that are talking about clots, but clot occur in blood when you put it outside the body. Thrombi form in the circulation. This is a fairly old study, but I think it's relevant even today. We looked at some 500 patients who underwent phlebography with a suspicion of deep vein thrombosis. About half of them had thrombi, half had not. And if you look at the patients that were treated for venous thrombosis over a 10-year period, they have a lot of complication in spite of the correct treatment, and that costs a lot of money. Of course, you can also have problems if you didn't have a thrombosis 10 years ago, but as you can see, there is a huge difference in the cost, and if you can prevent the problem, it's obviously very good for the patients and for the society. One problem when you look at venous thromboembolism is the different follow-up time. Some papers just look during hospitalizations, and then some days after discharge. Very common is 30 days, and now some papers have extended to 90 days. And at least it's very, very important to define which period you are looking at. Through the years, there has also been what I call an endpoint pendulum. When studies on thromboembolism started some 40-50 years ago, the outcome was mortality. Then came more and more sophisticated methods to diagnose thrombosis, and during the 60s, fibrin uptake test and then ultrasonography were used, and then came the discussion if this was a surrogate. I don't agree, as I said, with that, but nowadays we are back discussing mortality again, and of course mortality is important, but if you don't have a good autopsy rate, it's very difficult from a scientific point of view to discuss mortality. I worked for several years with the ACCP guidelines, and there we categorized risks for venous thromboembolism postoperatively into low risk, moderate risk, and high risk. And I think that most ERAS procedures are in the low risk procedure, although very few studies are made. Those are some fairly old data now, but they are from studies where prophylaxis was not used. And as you can see in what we call general surgery, mostly abdominal, around 1% fatal pulmonary embolism. And if we come to orthopedic surgery, the rate increases, and in hip surgery, some 4% fatal pulmonary embolism without prophylaxis. Also in so-called low-risk surgery, there is an activation of the hemostatic system. This is one of my PhD students some 10 years, 20 years almost ago, who looked at thrombin, antithrombin, fragment 1 and 2, and D-dimer. All of them increased in parallel in laparoscopic cholecytectomy as in open cholecytectomy. So there is also with so-called minor procedures and activation of the coagulation system, which of course is important for the pathogenesis of venous thromboembolism. The prophylactic methods that we have today are the heparins, vitamin K antagonists, which is not very much used because it's problematic. You have to measure INR, and there is a lot of interactions with other pharmacological agents. And down on the list you can see the new specific inhibitors of factor 2 and factor 10 in the coagulation system. And the rivaroxaban, dabigatran, and apixaban are all possible to take orally, which of course is one great advantage. There are some problems with the thromboprophylactic principles when you use either heparins or the new oral anticoagulants. There are studies on pre- and postoperative start. Some use it only during hospital stay. Some use it up to 10 days. There are combinations with other agents which could interact with venous thromboembolism or even promote thromboembolism as aminocaproic acid. I will not deal much with the start of prophylaxis, but the optimal time interval now, I think, is from the evening before surgery to some 6-8 hours after surgery. If you start prophylaxis within that time period, you have an optimal prevention. If you start much later or much earlier, the effect decreases. The other problem has been how long should we give prophylaxis, and the highest risk is immediately during and after surgery. And there has been a discussion if there is a new period of risk after discharge, and there are some data indicating that at least in some patient groups. We did this autopsy study very long time ago, but then we had a 90% autopsy rate. And as you can see, the majority of fatal pulmonary embolism occurred within 14 days. But there were some patients dying more than 30 days after surgery, and in that group you have major orthopedic surgery and cancer surgery. So some patients really have a prolonged risk period. And with those data, I designed 1993 to make studies like this, give prophylaxis for 1 week and then randomize the patients to placebo or active treatment and follow up for 30 days. And we used at that time elective hip surgery as a very good thrombotic model. And as you can see, with prolonging prophylaxis to 1 month, we could reduce the risk of thrombosis by about 50%. And then there came several other studies confirming this observation. And in all of the studies, various low molecular weight heparins were used. And we then continued with the same design using cancer patients. And again, we could, by prolonging prophylaxis from 1 week to 1 month, reduce the frequency of thrombosis. And that was repeated by a Danish study some years later. Now, how about ERAS and venous thromboembolism? I have looked through the literature, and there are very few original studies on this problem. There are meta-analyses and reviews which give some guidelines. And one problem, of course, is the terminology. For a vascular surgeon, there are various ways of talking about ERAS, and I've looked at all those combinations together with thrombosis and thromboembolic problems. As I said, there are very few studies with direct focus on venous thromboembolism. There are few, if any, randomized trials. There are, of course, historical comparisons and center comparisons. One problem is pulmonary complication, because that is often given, pulmonary or respiratory complications, but you don't know if that is pneumonia or pulmonary embolism or whatever it is. As I said, the autopsy rate is very, very low. And in many of the studies, thromboprophylaxis is not mentioned at all, or it's up to the surgeon, and you don't even give the duration of prophylaxis. So if you are interested in these specific problems, it's rather difficult. And I talk now as a non-ERAS surgeon. And the time for follow-up shows a great variation. Of course, there are factors that intuitively could reduce the risk of venous thromboembolism in ERAS. You have less trauma and you have less surgical stress. The fluid therapy is perhaps more optimal than after open surgery. You have less postoperative complication, which in itself increases the risk for thromboembolism. And the early mobilization and the short hospital stay probably counteracts the risk. The studies that in one way or other involves venous thromboembolism are those in orthopedic surgery, the gastrointestinal surgery, and the genitourinary tract. And going back again to Fredrik Lindberg, one of my PhD students a long time ago looked at venous thromboembolism after laparoscopic cholecytectomy in the literature. And as you can see, there were quite a few patients, 150,000, and the incidence of venous thromboembolism is low. And the incidence of fatal pulmonary embolism was 0.02%, which is a fairly low risk, I would suggest. A rather recent Cochrane analysis compared laparoscopic and conventional surgery for colorectal cancer. And again, you can see that there is a low risk of clinical venous thromboembolism, around 1%. But again, of the 25 studies, only 6 dealt with the problem of deep vein thrombosis, although they stated that they looked at postoperative complications. Now the studies I found were 17. This was about 5 months ago, with quite a few patients again, 13,000. None direct concerning prophylaxis, and in 9 of them there was no information on prophylaxis. And I think that's rather depressing, at least for me as a reader. And as you can see, there were different types of prophylaxis where low molecular weight heparins and rivaroxaban are shown to be effective. Acetylsalicylic acid has perhaps an effect on venous thromboembolism, but fairly limited. It's more on the arterial side. And the endpoint, again, pulmonary complication could, of course, hide some pulmonary embolism, as could respiratory complications. When I looked at it, there were 8 meta-analyses, and as you can see, there were quite a variation of articles, and again, no conclusions on thromboprophylaxis. Again, rather depressive for me as a reader. There are some recent guidelines on ERAS, and Ole Ljungqvist has been involved in most of them, and there are recommendations for prophylaxis, and at least in surgery for malignancy, there is stated that when there is an increased risk, prophylaxis should be continued for around 4 weeks. And in the recent ACCP guidelines and NICE guidelines, ERAS is not separated from conventional surgery. This is from Henrik Kellett's group and PhD thesis a couple of years ago, and there around this circle are the different ways to decrease the risk for complications after ERAS, and thromboprophylaxis is mentioned. And recently, Henrik Kellett published in British Medical Journal a sort of cohort study where they looked at postoperative venous thromboembolism after various types of ERAS, especially orthopedic surgery. It was published in British Medical Journal, and the risk of fatal pulmonary embolism is at least far below 1%. Perhaps down to 0.1%. But again, with quite a variation in prophylaxis, mostly during hospital stay, which is, of course, in ERAS patients quite short. I'll skip this one. And I would suggest to you that of patients with insufficient information on venous thromboembolic prophylaxis, I have had this list for quite a few years now, and I, for this lecture, added ERAS patients at the bottom line, because although, as I said, there are many indications that the risk is low, we don't have the optimal information yet. So my conclusion slide is also a bit busy, but the risk of venous thromboembolism seems to be very low. I think there are needs for randomized trials on prophylaxis, and I can buy your arguments that perhaps there are other problems that are more important, but at least the problem should be analyzed. And when cohort studies are made, why not include venous thromboembolism with very well-defined criteria? The need for extended prophylaxis is unknown, and again, that could be solved in randomized trials in high-risk groups. Multi-center studies should be stimulated, and especially those without commercial support from pharmacological manufacturers. Guidelines really need reconsideration, because also in the recent ACCP guidelines from last year, nothing is mentioned about ERAS. And when new risk categorizations are made, ERAS should of course be included, because this is an increasing field. And the health economic implications should be added. And as vascular surgeon, especially interested in aortic surgery, I'm of course quite interested that now this is also a type of surgery that is included in the ERAS concept. And especially, of course, if you use endovascular procedures, the patients could be made ambulatory, which is quite fascinating. When I started with vascular surgery, aortic surgery was high-risk surgery with patients 2 weeks in hospital. Thank you for listening.